Juan, obviously this is your first week here. Izzy and Iris have been here the last couple of weeks that we did this. So if you want to just give a quick introduction so they can get to know you.
Yeah, uh, Juan, certified athletic trainer, most recently with the Houston Dynamo.
Cool. There's no real like format or structure here. Juan, if you ever want to ask a question or if you want to comment on anything, feel free to share your experiences. We'll go through the slides that I prepared, kind of talk openly, and then like I said, feel free to interrupt at any time. So this week the topic was emergency transportation, and the continuing with the theme from the first 2 weeks. So we did cardiac care for the first week and then fracture care last week. So there will be a little bit of overlap here. Some of the same bullet points will be discussed, but the primary focus here was the actual implementation of emergency transportation. So quick overview of kind of what we'll go through, what we'll review. The EAP is probably the most common thing that you're going to have at all levels. There's going to be a little bit of difference in terms of the details and what needs to be included in those depending on where you're working. But for the most part, the EAP is going to be something that all ATs are implementing. EMS and the different times that you would or would not utilize emergency medical services and transportation there, the different staff assignments, so whether they are staying at the site of the injury or if they're going to go with the athlete to the hospital. And then lastly, we'll go through kind of follow-up care just briefly, the differences between which centers you might send them to. So for selected readings, different things that I found helpful in terms of preparing for presenting this, but then also just in terms of continuing education. If anybody's curious, wants to learn more about this, these are some directions that I would point you in. The EAP development is from the NATA, and all the links for these are going to be included on the slide. So after the presentation's over, then feel free to go back to the website and then you'll be able to find the links for these if you're curious or want to read more. The head first contact and what those injuries result in, particularly in American football. Acute management care of C-spine injuries, and that's similar or at least in alignment with the head first contact injury rates of American football. And then the last one is the FIFA set piece. This is kind of a newer approach here, but practicing the EAP, assigning roles and making sure that everything is clear so that if an emergency happens, everything is smooth, and hopefully you get good outcomes because of it. The last thing that I included is a video link. So I would strongly suggest that everybody watch the Daryl Conway risk management video if you haven't already. It's a longer video. It's about an hour. I did it a few years ago as part of the NATA's continuing education courses. And it was a really good video. It talks about emergency preparedness, the things that you might see in athletics, kind of how to triage or determine whether or not they need transported, that kind of stuff. So he works at the University of Michigan and does a really good job of talking about emergency scenarios that you might face as an athletic trainer. So the publication, the selected literature for this week was the epidemiology of injuries requiring emergency transport. And what they did was reviewed the incidence rates for college and high school student athletes, and then kind of broke down the different categories here of when these emergency transport injuries are more likely to happen or less likely to happen, so that you can kind of risk stratify here and kind of prioritize, okay, if I'm working with, for example, women's hockey, I know that I have to be dialed in during game situations, or men's wrestling, for example. So broke down all of the recorded or documented incidents where emergency transport was required. And obviously you can see, even though there were 339 documented injuries for college, that only comprised 1% of all injuries. So not a lot are going to require emergency transport from EMS. And obviously this is just what's documented. So there could be a little extra there, but relatively low number there for what to expect. You're probably unlikely to see one of these, but High school, even lower. Only 146 cases were documented, which is 0.3%. So again, really low frequency here. The kind of important takeaway from this slide is that the incidence for games was higher significantly for both college and for high school. And the risk goes up by about 4 to 8 times. So really need to be dialed in for games, EAPs, and that's pretty consistent across the literature. That's not just this study. I think pretty much everybody's aware that games pose a higher risk of injury, especially or particularly for emergency transports. Any questions, comments so far? Cool. So the sports that they broke down, and these are the numbers are athletic exposure or rates per athletic exposure. So it was per 10,000 exposures, and they define that as one athlete for one practice or game. Some literature dives in and kind of numbers them a little bit differently. So whether that is athletic exposure or exposure hours, you can get a little bit more precise. So depending on how accurate or thorough you want to be, exposure hours is a little bit more accurate. But for the sports that were most likely to experience emergency transport injuries, the highest overall was women's ice hockey for the collegiate setting, but similar injury rates that required transport with men's wrestling and men's ice hockey. And then a little bit different profile here in high school, football, wrestling, and gymnastics. And we can kind of talk about throughout the paper differentiated which body part or which pathologies were most likely to be sent via EMS. And we can kind of break down why these sports are probably the most likely to send somebody via EMS. But if you think about kind of like what we talked about with fracture care, player contact is a big risk injury for emergency transport. So if you see collision sports, something like an ice hockey or a football, even gymnastics, depending on the event that they're doing, you get a lot of force combined with player collisions. So that would be one potential risk factor, something to watch out for if you're covering those different sports. The top two mechanisms for emergency transport were consistent with both college and high school. The rates just varied a little bit. So for college, the surface contact was about 17%, and then the player contact was the majority. Again, thinking about when you're watching a game, when you're covering an event, what's the moment you need to keep your eye out and see if somebody gets up slowly or if somebody's not getting up. It's probably a player collision. So in soccer, the one that I'm always watching for, or the one that always scares me, is like a field player running into a keeper. That's a lot of force going opposite directions and high injury risk for both players there. So in soccer, that's the play that I'm watching for. In gymnastics, we talked about the fracture care last week. Depending on which event you're doing, this could be on the landing if they're on the trampoline, or this could be at the end of the tumble track, something like that. So kind of go through the different sports that you're working with and think about, okay, what's the most likely time that I'm going to have to see a big collision or a surface contact, depending on the nature of your sport. Another one that would be for soccer specific would be if there's a 50-50 ball in the air, both players jump up, coming back and then landing on the ground is a big risk factor there. So if I see that, kind of perk up a little bit and just make sure that everybody's okay. And then, like I said, same two risk profiles here for high school athletes. The surface contact is a little bit less, but then the player contact is a little bit more. So especially in the age group, the paper talked about the kind of risk profile for the skeletally immature and what the significance of that is. So especially if you're looking at like a lower limb potential fracture in somebody who's skeletally immature, you're thinking more along the lines of a fracture, less along the lines of a sprain or a strain. So if somebody's going down after maybe a surface contact, if they land awkwardly, maybe you're thinking, okay, it's probably a lower leg fracture as opposed to an ankle sprain, just because their bones aren't mature yet, they aren't quite as strong, and so they don't absorb force as well. Any questions, comments so far? Straightforward stuff. Cool. The body part, so then getting into kind of where they teased out the differences here, this is where you start to see a little bit of difference depending on the sport, but also the age group, whether that's high school or college. So head and face and then the neck are consistent across both age groups. But then the incidence goes way up for neck depending on if they're in college or high school. So the incidence is a lot higher, but then the overall percentage is about the same. The interesting point that they kind of highlighted within the body of this paper was that for most sports, or for all sports that were included in this study, the head and face were the most likely, and then the neck. But if it was a college football, then the neck goes way up. So it goes from 12.7% up to 21.5%. So again, you think about the types of collisions you're going to see only or most likely in football. It's that head down contact. And that's why those links earlier are so important, talking about the risk to the C-spine if their head is down, if they're leading with the crown of their helmet. And especially now, within the last, I would say, probably 3 to 4 years, they really started emphasizing the rule changes that are trying to protect these players. So leading with the helmet is considered targeting, and there's suspensions or there's fines depending on which league they're in. But yeah, so the head and face and then the neck. So if you think about, again, okay, well, if it's a player collision or if it's a surface contact, when are they likely to hit that? In hockey, for example, you have a little bit of a unique setting because you've got boards or walls that are around the playing surface. So not only do you have to worry about the head or face or the neck collisions to the rink, the ice, you also have to worry about, okay, if they slide across at a high speed, then they're going face first into the boards. Obviously, that's a pretty big risk factor there. So paying attention to those collisions as well as the player-to-player collisions that you might get in American football. Soccer, obviously, your head and face are going to be going up for a header. Maybe they run into a keeper, get an elbow to the face, something along those lines. So again, knowing your sport, knowing the likelihood of collisions, knowing the likelihood of head and face contacts, and then knowing the risk for C-spine injuries. The diagnosis was what I found the most interesting for this paper, because if you see the number one reported ETI for college setting was it was diagnosed in the ER as a strain, and the overall number was 50, but then that was about 15% of all of the referrals via EMS. So it kind of struck me as odd until I thought about it a little bit more. It's probably a misdiagnosis by the AT, or they're just being overly cautious. So they see somebody go down with localized neck pain, for example, or they lead with the crown of their helmet into contact and then they complain of neck pain. If that was associated with something like a stinger, for example, now they have a neuropathy, numbness, tingling going down their arm. And so then we're thinking, okay, well, maybe this is a C-spine injury. And so we're going to stabilize and we're going to send them via EMS. But a lot of times that x-ray is going to come back negative. So just kind of, again, being aware of the likelihood of it, but then also kind of like knowing your anatomy will help you in that diagnosis a lot. Palpating the right areas, gathering an accurate history if you can. Obviously, if they're unconscious or paralyzed, that could be difficult. But yeah, so I just found that interesting that the strain is such a high referral rate for EMS. Concussion, the most likely here is, obviously we know that we can treat concussions in-house most of the time, but the reason that they said they were sent most of the time was deteriorating condition. So if they felt like they were stable, routine concussion symptoms, presentation, but then they started to drop off, if they started to decline, or maybe their words stopped making sense. I had to send one. I was working with wrestling a couple of years ago, and I had to send a guy for this reason. Initially, he was saying, my neck kind of hurts, but I'm fine. And then after probably 5, maybe 10 minutes, he started drooling. And that was a big enough risk factor that I was like, okay, well, this isn't normal. And then he started getting obviously very emotional. He was getting pretty freaked out, pretty scared. So he was complaining that he couldn't feel his legs. And so that was a big enough risk factor that I called EMS for that event. So concussions, obviously, like I said, you can keep most of those in-house, but if you see somebody deteriorating pretty quickly and you are risk, if you're worried about somebody having some kind of a subdural hematoma, something like that, or even just you think that maybe there's a risk of a C-spine fracture that's associated with a concussion, don't be afraid to activate EMS if you need to. And then again, talking about the fracture incidence rates. So in college, you see that is one of the lower. It's the third most sent for ETIs. But then in high school, it's number one. So again, those skeletally immature athletes got to be aware that. And Izzy, I think you talked about this last week with the scaphoid fractures, the wrist fractures. Those guys are going to absorb force a lot differently than the college athletes whose skeletons, their bones are just a lot stronger. They resist force a lot better. So if you're working with that high school setting, being aware that fractures are probably going to get sent more often than something like a concussion or something like a strain. Questions, comments? Anybody have some cool stories to share for different diagnosis or different times? Anybody ever have to send somebody via EMS?
Yeah, I've sent two.
What was it?
The first one was a male college soccer player who received a concussion in the first half. Didn't report it until halftime when he said he couldn't see left or right, and so he only had tunnel vision. Uh, Deteriorated mental, all that. So we sent him for observation. We were at Florida Gulf Coast at the time, and this was when I was at USF. Um, so he ended up being fine and actually recovered within like I think 10 days afterwards. He was back playing. His concussion symptoms were resolved and he cleared his protocol, which was interesting. Sorry, my dogs are playing in the background.
You're good.
And second one was they called it a spinal cord contusion. Um, Another male college athlete working in a Division II setting. I was evaluating another athlete for a potential concussion. Sorry, uh, and so I didn't see the mechanism, but he was hit from behind pretty benignly, just kind of like any kind of riding the challenge, if you will. Um, Took a couple more steps and then went down. And when I went over, he said he couldn't feel his left leg. So transported and he ended up getting his feeling back within, I would say, 7 days. He was back to fully functional with no deficits.
Nice. So what would you say, like, what was your biggest lessons learned from those? Obviously, your first time activating EMS is a bit nerve-wracking. You might make some mistakes that you look back at and you think, oh, I could have done this differently. What did you learn from those two?
The first one was pretty cut and dry. So it it was just kind of seeing and knowing the athlete and sending him off based off of that. Um, and it was just surprising that even though we sent 1 second. Apologies. And then even though we sent him and he had loss of vision, vomiting, and deteriorating mental health, he was back relatively soon. So even just like first presentation isn't always indicative of how the recovery is going to be.
Mm-hmm.
At least in the concussion realm.
Yeah.
The other one was just really interesting in terms of like what the reported mechanism was and how it presented, but on actual on-field care and management, I ruled out C-spine and stopped holding C-spine because he had no mechanism, no nothing. But looking back, I should have continued to hold on to C-spine because even though he had no head or neck pain, no like radiculopathy going down to his upper extremities or anything like that, just better safe than sorry in that aspect.
Mm-hmm. Yeah,
Um,
I think those are both really good points, and I think that particularly for students, Iris, correct me if I'm wrong. I think that the kind of subjective learning experience and what you take away are really valuable. Obviously, you learn the textbook way, or you learn the kind of cookie cutter. Oh, if you see this, then you need to call 911. But they don't teach you about like, okay, well, what do you do if you're stabilizing in the middle of a game and you're there for 15 minutes and the referees or the coaches start getting on you and saying, can we finish this game, that kind of stuff. So I think the subjective kind of learning experience is really important for these emergency scenarios.
Yeah, and on the other side of that is this happened with probably 30 minutes left in the game, and so like the game still continued.
Mm-hmm.
So I was a relatively fresh grad, and so
Mm-hmm.
like that being my first big injury occurring in the middle of a game, like you still had to get on with it. And
Mm-hmm.
so kind of compartmentalizing that a little bit in the game, and uh, kind of presenting a calmness to the rest of the athletes and coaches to give kind of that sense of poise.
Mm-hmm. Yeah, we talked about that last week with the fracture care and the importance of providing that kind of calm, cool, collected presentation so that everybody else around you can kind of interpret that as, okay, he's got it under control. Everything's going to be okay. We can move forward. But yeah, I mean, like to go back after something like that happens, and then you're going back into a game, and then you're trying to pay attention to the game. Obviously, there's still a risk of injury for the other players that are still there. So to kind of flip that switch and move past it, even though in the back of your mind you're kind of wondering, okay, well, I'm assuming you didn't go to the ER with this guy, but if you sent him to EMS, you're wondering, okay, well, how is he going to do at the ER? What's the follow up going to look like? All those kind of questions. So that's an important piece to kind of consider. And then the other thing, you said you were at a different school. Obviously, you were traveling for a road game there. Any confusion or how was the activation of EMS on the away scene? Obviously, that's not something most ATs are going to prepare for in their own EAPs, but it's kind of relied upon for the host site. So, what was your experience with that?
Yeah, it was a pretty easy actually, because we just talked to their AT and told them what the situation was. They had a team doctor on the sideline, and so we just talked to them and we're like, hey, like we think we're gonna send him to the hospital. His parents were there, so he just went with them, and so they stayed overnight, and we just got all the contact information. Um, but it was pretty straightforward.
Gotcha. Yeah, so that's a local one. How far away were those two schools?
Uh, FGCU is in Fort Myers and Tampa, so it's about 3.5, 4 hours,
Gotcha.
I
Yeah,
think.
because something that I've always kind of been fascinated by or concerned with is even when I was back in grad school, I was working women's basketball, but we were based in Illinois and we would have games up in North or South Dakota. And then obviously now we're in Houston, but we travel to LA or we travel to Seattle or Vancouver, those kinds of places. And so the kind of continued care there is an interesting concept that isn't talked about very frequently. But if you have to leave somebody overnight, for example, like in your case, but maybe you've got flights booked for that night, maybe the team is leaving right after the game, so all kinds of kind of complications that can arise that the AT has to navigate. It sounds like it went okay for you.
Yeah, yeah. Um, I just realized that I had one sort of. It wasn't that we activated EMS, but he ended up going to the emergency room. It was a high school basketball athlete uh, who had pretty much full body cramping that wasn't improving, and so he had to go and get an IV and all that. But his parents wouldn't allow us to call an ambulance for him, and so they wanted to drive him.
Hmm.
So I think that's another layer that you kind of have to take into consideration at the high school level, and why there's most likely, because there's a minor that you're going to see those less incidences as well.
Hmm. Yeah, and going back to the EAP, kind of in that overview, all the different things that you have to prepare for. So the roles and responsibilities, obviously, the ATs are going to handle most of that. If you have a team doctor that's on site, they're going to help out. but knowing your equipment, knowing your map, your directions, which hospitals are in the area, the different pathologies you might see. And so, for example, if you're an outdoor sport, basketball players very rarely see these kind of heat illnesses, but maybe if you're working with cross country or soccer, something where they're out there for a long period of time, or if they're wearing pads and a lot of heavy equipment like in American football. So again, being aware of the different things that you're going to see, knowing the epidemiology of your sport, of your competition level, that will help you kind of plan for as many of these kind of contingencies as you will see. Because there's a million different things that you could never predict, but as many as you can cover in your EAP, try to cover those roles and responsibilities, that kind of stuff. Anybody else have any other short stories they wanted to share? Izzy, you have any referrals via EMS?
Yeah, I've heard a few at the middle school level. One of them, I literally only called EMS because his parents weren't there, and it was like an away athlete. So that was the only reason why I called EMS. It was for like an elbow injury. I really didn't think he needed it, but because his parents weren't there and he was like very overly dramatic and like didn't want to move, I was like, well, if I'm gonna split you, I might as well call EMS. And then there was another one where a girl ran headfirst into a wall like during a basketball game. So I called for like possible C-spine, but I didn't get to like stabilize because where she fell was like in the corner of a wall, so like I couldn't get around to stabilize. But it ended up just being a concussion, but I was just being extra cautious because she went headfirst into the wall.
Yeah, so you've got basically all of the talking points from this paper. You've got the epidemiology pretty much nailed. You've got a high school athlete that was sent via EMS for a concussion. The mechanism was a surface contact, and you were ruling out a fracture. You obviously were concerned about the C-spine there, but ultimately is sent with and diagnosed with just a concussion. So this would kind of fall in that category of not end up needing the EMS, but better safe than sorry from the athletic trainer's perspective. The end of the paper was kind of interesting. They talked about the overuse of EMS and how the burden of athletics kind of drains the resource for the rest of society. And I found that kind of weird but interesting that there's so many kind of mismanaged ETIs, for example. They talked about the strains for the C spine. If we're sending all these people via EMS with just a C spine, or not a C spine, but a neck strain, for example, now EMS is getting there, and somebody obviously that there's a limited, no matter where you are, even in big cities, there's a limited number of ambulances, and so there's one less because you just sent a neck strain. So I think it's kind of a dilemma or a catch-22 of, well, you better safe than sorry with neck, and you don't want to miss a C-spine, but at the same time you don't want to overburden the ambulance system, and you don't want to take away from somebody who might be having some kind of like a cardiac event, for example. So if you're in a small town and they only have, say, 3 or 4 ambulances, now you've used one, and if there happens to be 2 or 3 other emergencies happening at the same time, that creates quite a conundrum. But any other questions, any other comments before we wrap up? Any other cool stories anybody wants to share? Cool.
As a
So,
student, I haven't been a part of a EMS call yet. All of the ones that I've had, like at the high school level, were all ones that their parents were there and they transported them with the car. But me playing soccer, I've had a couple of teammates that had EMS activated for them. One of them was pretty much whiplash, but she was C-spine on the field for a while. And then the other was a fracture. I think it was just her tibia. It could have been tibia, but I think it was just her tibia. But those are the only ones I've seen like in real life was my teammates.
Mhm. For the C-spine case, how long were they holding that C-spine before EMS got there?
It felt so long because we were like out in the middle of nowhere, Alabama, and it felt like it was like hours, but I'm pretty sure it was like 30 minutes, 25 minutes.
That's still a long time to be holding C-spine.
Yeah, it was pretty tragic. It was so bad, but she ended up being fine. It was whiplash, and they did all the things for her while we were still there. So we had to like wait out in the parking lot for her because it was like the game, and then we had to just leave. And then we had our AT went in with her to the hospital. So we're just all just waiting in the parking lot for her to get discharged, and it was a whole thing.
Mm-hmm. Yeah, that's where part of the EAP planning is knowing obviously where the hospital is, how far of a drive it is for if somebody like a parent is going to take them to the hospital, but then also knowing, okay, if the ambulance is coming from the hospital, they have to go both ways. So it's a longer commute to even get them to the hospital. And so that's something to plan for is the duration. And a lot of EAPs now are starting to have, they basically just take a screenshot if you use like your Maps app. You take a screenshot of the duration or how far away that hospital is, depending on obviously traffic. It could take them in a big city easily 20 minutes, or if you're in a small town that's out in the middle of nowhere, same thing could take 20, 30 minutes. When I was at Camp Woodward, I mean, we were sending kids every day, but a lot of them, if they could wait, we would send them all in one big van. Basically, we would just have them stabilized if it was a fracture, stabilized, and then if they could wait, if they didn't need EMS, we would send one big group at the end of the day, send them all to the hospital at the same time because we were an hour away. And so again, planning for the durations of, okay, if an emergency happens, is the EMS going to be able to get there in time in order to help, whether that's a C-spine or a fracture or a concussion, or if we go back to week one with the cardiac events. So knowing the time to expect for the AT to kind of plan and prepare the different resources that you have on site, that'll help with that stuff. So you're not sitting there wondering, okay, I've been holding this guy's neck for 30 minutes. When is EMS going to get here? So kind of to review, the EAP is huge, and the more detailed, the more thorough that it can be, the better. Try to narrow in on sport-specific incidents that might happen. Assign roles and responsibilities for your different staff. If you work with soccer, you can use the FIFA set piece program and really assign even to the location of the staff that's going to help out with the emergency, where they're going to stand, where they're going to respond, what their responsibilities are once they get there. What equipment you have on site. If you have a spine board, if you have AED, if you have splints, that kind of stuff. And then the map and directions we touched on already, the different hospitals. If they're going to be a trauma, do they need to go to level 1? Or if it's just a local hospital, if you're in a small town, are you going to send them to a local hospital? Or are you going to send them up to like a regional hospital? And then knowing the different pathologies that you're likely to see based on the epidemiology of your sport. If you're likely to see fractures, if you're likely to see strains, if you're likely to see concussions, or like we talked about in week one again with the cardiac events. So knowing your sport helps. Knowing which actions to watch for, the player collisions or the collisions with the surface, definitely helps as well. And then deciding ultimately, are you going to utilize EMS, or are you going to have them go with their parents in the back seat? Are you just going to splint them and then drive them? Can they wait until the end of the day, or is it urgent? Do they need to get to the hospital right away? And then the follow-up care, obviously deciding which hospital to send them to, who's going to meet them at the hospital. Are they staying there overnight? Are they coming back that night? Are they going with a parent? Does a medical staff need to go with them? Is the doctor going to meet them there? All those kinds of things need to be mapped out in the AP, and that helps those emergencies go a lot smoother if they arise. Cool. So that wraps up this week. So next week is going to be time management, and really mapping out the kind of what we were talking about for what to expect for different emergency response teams. So, and then month 2, sorry. Let me pull it up real quick. February gets into strength and conditioning. So if anybody's interested in strength and conditioning, then February is your month. There's gonna be a lot more physical preparedness that will be in the discussion. January was all emergency care. So we'll start to get into a new topic after emergency time management next week. Thank you all again for being here, and hopefully we'll see you next week, or if not, we'll go see more going forward in the future.